What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Welcome everyone to the Breathing Lab with Dr. Jenny. So excited to introduce Patrick McKeown, a wonderful breathing retrainer, a mentor of mine. And I just wanted to spend a little time introducing him so that you know what he has been up to all these years. Patrick McKeown is a leading expert in breathing and its impact on asthma, sleep, and mental health, with over 2 decades of experience in breathing re-education. He has authored 12 books on the science of breathing, including the internationally acclaimed The Oxygen Advantage, and has a forthcoming book, The Sleep Cure, set for release in June 2025 by Humanix Books. His work focuses on functional breathing, sleep-disordered breathing, and nervous system regulation, offering practical techniques to improve respiratory health, sleep quality, and mental well-being. His research has been published in the Journal of Clinical Medicine, and he collaborates with leading experts in medicine, sports performance, and neuroscience. Patrick trains healthcare professionals, athletes, and individuals worldwide, helping them harness the power of optimal breathing for better health, sleep, and resilience. So I wanted to share, Patrick, thank you so much for coming. I'm going to share just a quick slideshow of some really neat times we've been together. Okay, so here we go. This is Patrick and I in Collaboration Cures. We've been to several Collaboration Cures together. This is an AAPMD is a group that is multidisciplinary. So it brings together many different disciplines around breathing and airway health. So this is us here in 2022, though there's been several. He's a speaker. I've spoken at this conference several times. He's an international lecturer in breathing retraining. Patrick travels all over the world teaching the Buteyko Breathing Method and Oxygen Advantage. This was the recent 2024 AAPMD conference in Reno, where I have both my mentors here with me. This is Mariano Roccabato and Patrick McKeown here on one of the social events they had there. So much fun. So great to have such brilliant minds together collaborating. So just a couple summers ago, I was able to go to Europe and visit Patrick, and he gave us a wonderful tour of Galway area, the countryside. He lives in such a beautiful home there, but this is my husband. And we were there visiting. This is my daughter, Isabella and Clyde, and my friends from Spain that were visiting. Patrick was so kind to host us there and just give us such a nice tour of that area. I was also able to visit Buteyko International, and I saw where he does his magic, where he teaches the public and teaches healthcare providers. He has a beautiful setup, very, very comfortable for learning. So it was just neat to see that. And of course, Patrick's an amazing writer. I'm sure you've read some of his books. Every single one of them is fantastic. This is him signing a book. I think it was The Atomic Focus. But these are all the books that he's written. I mean, really around asthma, mouth breathing, Buteyko on sleep, really yoga, how Buteyko can be used in our yoga practice. And just it's an amazing set of books that I think is supportive of anybody really dealing with any kind of breathing disorder.
And if you're interested, I am also teaching a course called the Intro to Airway Eval and Treatment course, and I'm teaching how I've incorporated the Buteyko Breathing Method and really brought it into my practice as a physical therapist and used it and intertwined it with all my patients. So if you're interested, you can use that as the QR code to connect to where you can sign up. And the next breathing lab, just so that you can prepare for the next one, will be on May 1st at 6 p.m. with Lois Laney, the cranial nerve integration specialist. So mark your calendars. Also, I will be speaking at the July 24th to 26th American Dental Association Children's Airway event. So just wanted to give you an update on that. And if you wanted to join that, here's the QR code and you can sign up there. Okay. Patrick, thank you so much for making the time to join us today and share your knowledge around all the things that you've learned since we last met. I can't wait to hear some new research and new information that you have to share with us. So thank you and welcome. So Patrick, what I wanted to share with you is, and to the audience, is we met back in 2013. You can remember, it was many years ago. And I originally took the AOMT myofunctional therapy course by Joy Moeller. And that blew my mind because I myself never realized I had my own myofunctional problems, right? I didn't realize I wasn't really using my nose, that I was breathing through my mouth, that I was tongue-tied. So I had no idea. And, thanks to the AOMT, they all kind of all take Buteyko. So I was introduced to your work and Buteyko's work right after that course. So 2013 was a huge year for me. I was able to understand the craniofacial development issue that I had myself. And before that course, I didn't realize I was mouth breathing, tongue tied. I had those 4 bicuspid extractions because I grew up tongue tied, mouth breathing, narrowed, crowded. So the dentists at that time were pulling teeth, which made me small in the face and small in the nose, kept me very narrow and long. So what I learned in your course is that people that mouth breathe overbreathe, that they breathe too much volume. And that is really changed my life because I was someone that was yawning all the time, sighing all the time. I would sleep 7 hours a night, and the first 2 hours of waking hours were yawning, as if I was exhausted, and I was. I didn't realize that. So I learned from you, and I'm so grateful that a consistent flow of gentle nasal breathing at a normal breath rate keeps the walls of the airway open and stable and less likely to collapse. Therefore, not just restoring nasal breathing. Some people think, okay, I'm going to tape my lips and I'm going to just nose breathe and I'll be fine. The volume does not change to normal just like that. You really have to work on reduced volume breathing. And I have found that this is difficult for patients because they're used to breathing the way they were breathing and they get really scared and feel a little suffocated when they start reducing their breathing. So we're going to be talking about that in a little bit, but I'm so grateful for you. I'm so grateful for your ability to connect to so many people and change so many lives. Patrick, you're an amazing communicator, and I so thank you for being here and spending some time with us today. Thank you so much.
I think breathing is often forgotten about. And when people think about breathing, everybody has their own perception about what does it involve, what does breathing training mean. Whereas we have to think about breathing in terms of different dimensions It's simple and complex at the same time. It's a little bit like sleep, but there's a really strong connection between how we breathe, our everyday breathing patterns, and how we breathe during sleep. So, for example, in short, if somebody has insomnia, which is pretty common, it's about 30% of the Western population, and 10% of people have it chronically. That can be very often driven by hyperarousal. So the individual is in an increased stress response. And of course, maybe they're having a really stressful day, might be one-off, but it could be chronic. And the hyperarousal from the day carries into sleep. But then they're having really poor sleep. And that's reinforcing the hyperarousal, which in turn carries into the following day. And it's almost like a vicious cycle. And the traditional remedy is to prescribe medication or cognitive behavioral therapy. And 8.4% of the US population take sleeping pills. And we have to ask, what's the purpose of the sleeping pills? Well, it's to help to dampen and quieten the mind, but it's also to help with that is to dampen the stress response. But you can ask then the question, well, could breathing training assist with this? Could we help to reduce the stress response and increase the body's relaxation response? Could we help to get people out of their head and going beyond mindfulness? You know, this isn't just about paying attention to the breath. I think what people don't really realize sometimes is that if you breathe a little bit less air, you can increase blood flow to the brain. And you can increase blood flow to the brain by between 5 and 10%. And if we think of the brain as an organ that consumes 20% of our oxygen, even though it's only 2% of our body weight, so it's a very hungry resource in terms of its consumption of oxygen, but we can influence that through our breath. And there's also other aspects, I suppose, Jenny, in terms of in 2017, Stanford Medical School, they identified that there is a structure in the brain that literally spies on your breathing. And this structure is in the brainstem. And if you're breathing a little bit faster and harder, your brain then is interpreting that your body is under threat. And your brain, of course, is here to protect the body. So your brain puts you into this fight or flight response to get you out of the situation. But it can also awaken us from sleep. So even just with insomnia, people waking up at 2 or 3 o'clock in the morning, what may be a factor that's contributing to that? 1 is hyperarousal, 2, overthinking, and number 3, poor breathing patterns. So there's one example. Now, then, if, for example, if we're looking at upper airway resistance syndrome, and nobody really knows, is it a continuum from snoring right up to obstructive sleep apnea? But with that, it's very common for people to be light sleepers. And in essence, what they have is, it's called low arousal threshold. In other words, that they wake up quite easily from sleep when there's an effort in their breathing patterns. And if we think about upper airway resistance syndrome, it affects primarily females. And they don't meet the characteristics of what you typically consider for somebody with sleep issues, because a lot of the sleep business is all around men. You could argue that females have been forgotten about entirely when it comes to sleep. Because if a female does a sleep study, if her AHI, the number of events that she's having per hour, if it's less than 5, it's seen as non-significant. But a female with an AHI of between 2 and 5 events per hour is equivalent to a man having an AHI of between 10 and 15 events per hour. And the symptoms from a female having poor sleep is very often anxiety and panic disorder and fibromyalgia and chronic fatigue. And those wouldn't necessarily be the same symptoms that a man would experience when he has poor sleep. So the diagnosis of sleep issues in females is trickier because the female can still have symptoms even though she doesn't have sleep apnea per se. She doesn't have to have her blood oxygen saturation dropping. But if there's a narrowing of the airway, which in turn is causing an increased effort to breathe, that increased effort to breathe can take her out of deeper sleep. So she spends more time in light sleep and less time in restorative deep sleep. And then she has symptoms. But of course, sleep studies then don't necessarily pick up on this. And then, of course, you have to think about females then post-menopause when there's a reduction of progesterone, because progesterone is seen to help to protect the airway from collapse during sleep. So they're part of the throat, that can collapse in 4 different places. That older females, well, my age group, 50 years of age plus, that they're more prone to sleep issues. Sleep disorder breathing increases by 200 and 300%. And just finally, to kind of bring it around, obstructive sleep apnea as well. Very often the emphasis is looking at the airway. And of course, we don't want to have a narrow airway. A wide airway is better because there's less effort to breathe and there's less resistance or restriction to airflow. If you have a wide pipe, it's easier for fluid or air to flow through it versus a narrow pipe. It's going to increase resistance, and that's not good. But it's not just about the diameter of the airway. We have to consider, how is the person breathing? If they have their mouth open, their tongue is in a low resting posture. The tongue is more likely to encroach the airway to narrow the airway. The lower jaw, the mandible, is set back, which in turn is reducing airway size. Because they're mouth breathing, they're more likely to be breathing upper chest. You can see that yourself. And because of that, they're likely to be breathing faster. And that in turn feeds into airway collapse. And mouth breathing is also going to dry out the airways. It dries out the mouth, it dries out the throat. And this in turn can be traumatic to the airways, contributing to inflammation, which in turn is going to narrow the airways, which in turn increases the risk of collapse. So we need to go beyond, where does it start? Well, there's one airway. There's no such thing really as an upper airway and a lower airway. Because whatever happens in the lungs and the diaphragm is also going to be moving upstream. And whatever happens upstream is moving downstream. So it's a unified airway. And if we think about the upper airway dilator muscles in the throat that are designed, or their function is to keep and maintain an open airway during sleep, those muscles are connected mechanically with the diaphragm. So then when we're thinking about, well, how do we have to prevent collapse of the upper airway during sleep? Well, we need to look at breathing patterns, but we can't just look at the biomechanics of breathing. So again, a lot of the emphasis is on the diaphragm. And of course, good function of the diaphragm is important because of it helps with stiffening and dilation of the pharyngeal airway, the throat. But we also need to look at the drivers to breathe. If that person is breathing hard and fast during sleep, why are they breathing so hard and fast during sleep? Do they have an increased drive to breathe? And of course, the primary driver to breathe is carbon dioxide. And then we ask, what is this faster and harder breathing doing in terms of increasing resistance to breathing? So the sleep industry has really focused on the airway diameter, but hasn't focused on what's expected to go through it. Hasn't focused on how fast is the person breathing in their normal everyday life? How hard are they breathing? Where are they breathing? Are they breathing nose, mouth, or are they breathing high or low? So that's obstructive sleep apnea. And I'll just kind of finish it with snoring. Mouth snoring, it sounds like this. I don't know if it'll come across in the mic, but it sounds like this. It's a very throaty sound. And once you get your mouth closed during sleep, you stop mouth snoring. You cannot mouth snore if your mouth is closed. In order to snore through your mouth, you have to be breathing through your mouth. So mouth snoring we can stop. And of course, we want the mouth closed with the tongue resting on the roof of the mouth. And then nasal snoring sounds quite nasally. So you can differentiate by the sound. If you were to record somebody snoring, you'll typically identify if it's a mouth snore or if it's a nose snore, just by the sound of it. But again, with nasal snoring, like the turbulence that's happening inside in the nasopharynx where the nose is meeting the throat and inside the nasal cavity, that's not just related to airway, but that's related to the force of the airflow that's going in and out through it. Now, one might say, well, the person has a narrow airway, which in turn is going to increase resistance to breathing, which in turn is increasing breathing. It comes faster. That's true. But what if the person has an underlying breathing issue and they're naturally breathing a bit faster and harder anyway? So then you have a narrow airway combined with poor breathing patterns. So now you have a double whammy. You have two factors that are feeding in. But again, only one is addressed, the airway. And personally, I think the sleep industry has really not moved on. If we look at, I'll give you stats on obstructive sleep apnea. It affects 936 million people on this planet. 85% of them are undiagnosed. Only 15% get diagnosed. Of the 15% that got diagnosed, only 40% accept the treatment, which is CPAP traditionally, the gold standard of treatment. And of the 40% of people who accept the treatment, 50% of people abandon it after 3 to 6 months. Now, we think of all of the effort and resources that are pumped into the sleep industry. And yet, if you have 100 people with obstructive sleep apnea in a village, only 3 of those people are getting treated at any one time. Now, if that result applied to any other industry on earth, you would say it was a dismal failure, but nobody seems to
Right.
be talking about that. And that opens the way, surely one should be curious about, well, everyday breathing, myofunctional therapy, and other aspects that can be done, giving people the tools to help.
Thank you for that. Now, what I wanted to talk to you a little bit about is sleep. A lot of people struggle with sleep, and they may not realize that their noses aren't working. They might not realize that their nose is a big problem. What I've realized myself is I had a deviated septum. I only knew that because of a CBCT X-ray. And that was after I was doing some palatal expansion as an adult. So I'm still very narrow. I struggle to breathe through my nose. Anytime it swells up, that submucosa, the blood vessels that swell, that limit the airflow through the nose. If I have any of my, not that I'm allergic to things, but I have food inflammation, and my nose will swell. And then I struggle through breathing through it because of the architecture being so narrow. But I don't think the nose is always being addressed in patients. They kind of say, oh, my nose is fine. They don't realize it. They don't understand what's happening underneath the face and underneath in the bony structure of the nose and the septum. So if the nose doesn't work well, you're going to be a mouth breather. You have to be, just because the nose isn't going to be able to bring in that air. So once the body gets used to mouth breathing, you're kind of stuck unless you meet someone like me and someone like you that will allow that individual to start learning how to open up those passages, keep them open, and then reduce that breath volume. Now, I might tell patients to go see an ENT. There's some that will go and some that will not. Some people are afraid of doing anything to their nose. And I'm like, you know what? The nose is where the health is. And I always remember, you taught me if you start breathing a certain way, like for 24 hours, say you had a car accident or you broke up with your boyfriend or girlfriend and a traumatic event, and you breathe big because you're upset and you're breathing heavy because you're really, you're on fight or flight, your body will get used to that volume. So that volume, you need to learn how to change that. And a lot of people don't, they've never taken Buteyko Breathing Method or Oxygen Advantage, they won't understand, what does that mean, the volume? People all think that they breathe fine. So I always wear a nasal dilator. I don't try to tape my lips, which I learned from you in 2013. So thank you very much. That changed my life. I stopped yawning from just taping my lips at night. That's all I did with a Breathe Right strip. And of course, I've been working on reducing my volume since I met you. And when I'm stressed out, I really have to work on it. But this brings up a topic I wanted to talk to you about, which is mouth taping. Now, you are brilliant and you've created the myo tape, which is, it's like a little kinesio tape that goes around the mouth with the mouth open or the mouth uncovered, and it kind of brings the lips together. Perfect. And I use that for all my children that I treat in my practice. Now, for those, I don't know if you're still using 3M micropore tape like I've met you originally. That's what I like still. I still put them back in the hand and I put it on my lips after I use my Breathe Right strip. But what is your stance on mouth taping? It is something that has come up, in social media. A lot of people are trying it. I don't tell everybody to do it, but when it's a patient that has sleep apnea, high blood pressure, any kind of, severe diagnosis, I say you are not ready to do any of that. What about an athlete that or someone that doesn't have those types of diagnoses, what would you recommend? What is your stance on mouth taping?
Yeah, like for about 17 or 18 years, I only had one option. That was 3M 1-inch micropore tape. And in fairness, it worked pretty good. You know, everybody who would come in, I would give them a roll of tape. There was a couple of problems around it, though. One was children. You know, we couldn't be taping children's mouths. And I was always trying to find out, like, should I bring the tape this way and this way? And never really worked that well. And the other aspect might be, say, for example, people who you're a little bit cautious or concerned that they're not adequately nasal breathing, and you don't want to force nasal breathing either. Whether it's a child or an adult, you don't want to force it, because that's going to increase stress, and it could put a little bit of stress in the heart in terms of that increased pressure, that the effort involved with breathing. So I would love to see mouth closure becoming mainstream, but I don't think it's going to become mainstream as long as we cover the mouth. And that's really a quest. So with my own clients, I typically, I have my tape in stock. I always have it in stock, and I just give them it, so it's easier for me. We have a big bulk of it, but it's safer. And especially if you have somebody with anxiety and panic disorder, it's safer because sometimes they feel claustrophobic if I ask them to keep their mouths closed. With children, I really don't feel comfortable with asking a child to tape their mouth. Even though we only, it's using mouth tape with children over 4 or 5 years of age. And I suppose the other question then, Jenny, is, we do need to get the mouth closed. It is huge. It's absolutely vital. And it's not always easy because, yes, there can be mechanical issues there, but one can use simple tests. So say, for example, a child comes in and the child is coming in with the mouth open, and I have the child do a client questionnaire, and we assess in terms of, okay, what's the issue with the child, their nose, their lungs, etc. I might just pull up the questionnaire just to kind of give you an idea. This is a more recent one. And then I'll kind of go through the test that I do in terms of so this here. Okay, so this is a questionnaire that children come in. Obviously, it's filled out by the parents. So we want to find out, in terms of the nose, how well is it working? Is the nose stuffy? Do the child have hay fever? Do they have animal dander issues or allergies to dust mites, animal dander? Is the mouth open during the day? Sometimes the parents aren't always aware of it. And then they might say, yeah, during mealtime, the child is poor table manners, noisy eater. And so the parents fill out this. Then we ask about the lungs, any symptoms, because very often if there's symptoms of the lungs, it's never just isolated to the lungs. It also travels up to the nose. Coughing, wheezing, breathlessness, head colds, exercise-induced asthma, shortness of breath during physical exercise. And then the child's breathing pattern. Does the child run out of air while talking? Do they have a faster breathing pattern? Do they have audible breathing during rest? And the reason that I put these questions together was because I couldn't find a questionnaire that was available that looked at breathing in children. Now, there may be one out there. I just couldn't find it. So then looking at sleep, is the child sleeping with the mouth open, or do they have audible breathing during sleep? And we shouldn't hear any child breathe during sleep. And not because the child has stopped breathing. The child should be continuously breathing during sleep, but silently breathing. Because even audible breathing during sleep indicates that there's some restriction to their airflow during sleep. And just as breathing and sleep in children or in women is different to men, well, sleep and breathing in children is different to adults. Is the child snoring? Is the child stopping for at least 2 breaths or more? Again, that's one apnea. And all a child has to have is 1 apnea per hour before it's clinically significant. Does the child have broken sleep? Bedwetting. If the bedclothes are trashed in the morning, excessive daytime tiredness. Now, children don't typically be, tired. It's more their state of mind that's impacted by poor sleep. So say, for example, worrying, having negative thoughts, a lot of noise going on in the mind, getting angry quickly, out of control during outbursts, feeling tense or fidgety, leg bounce. And then academia can be affected, hyperactivity disorder, difficulty in school, dental, and then any of the conditions. And we do specifically want to find out if a child has pulmonary hypertension, because we don't work, there's a contraindication there. Cardiovascular disease is the same. I don't want to put any stress on the child with breathing exercise. Epilepsy, we go easy. Eczema, we work with. Diabetes, we go easier. And asthma, we don't go easy, we push. Once the child has got good control. So typically what I have the child do is a nasal breathing test, because the last thing we want to do is forced breathing in and out through the nose, because that's going to put too much of a stress on the child. And if a child is coming in with the mouth open, we have to ask, why are they having the mouth open? Is it nasal obstruction or is it mouth breathing habit? And very often the two go together. But if it's nasal obstruction, is it the front of the nose, rhinitis, which we can help address, or is it the back of the nose, enlarged adenoids, which is different? So I have the child do the nose unblocking exercise, 6 repetitions, and then I have them sit down and wear paper tape across their lips. This is 3M 1-inch micropore tape during supervision. And is the child able to breathe through their nose comfortably for 3 minutes? Now, if a child has got enlarged adenoids, and if we have them wear a little piece of paper tape across their mouth, when they're breathing through their nose, they feel that they're not getting enough air. If the adenoids are enlarged, they'll keep on ripping off the tape. But you will also hear them struggle a little bit. You'll hear that their breathing is audible, it's noticeable. You'll get a sense that, yes, they're not finding it comfortable. After that, then I actually have them wear the paper tape for 3 minutes again, but I asked them to walk and jog with their mouth closed. Because if a child can jog with their mouth closed, I'm comfortable that the child is able to breathe through their nose anatomically. Because especially if you increase your metabolic activity, if you start doing physical exercise, and if the child can sustain nasal breathing comfortably, of course, they are going to breathe faster, a little bit harder because of the increased physical exercise. But you're looking to check, how are they breathing relative to their physical exercise? So this is where I want to kind of it's for me to get a guide as to whether I can work with this child. Because if the child has enlarged adenoids, well, that's going to be back to a doctor. But if a child has just a stuffy nose because of rhinitis, we can help that. Now, depending on the age, but say children from 5 years of age up to 16, I would say that 75% of them, we can get them switching to nasal breathing. And the younger kids especially, or children prone to sleep disorders, they're going to be a referral back to ENT. But the only thing that I will say is, it's unfortunate that most ear, nose and throat doctors are not necessarily aware of breathing re-education post-surgery. And if the child doesn't restore nasal breathing post-surgery, there's a worsening in their sleep apnea within 3 years. So it's tonsillectomy and adenoidectomy is short-term unless nasal breathing is addressed. So it's the same with children and adults, Can you breathe through your nose comfortably? And if it's the front of the nose that's causing the obstruction, because nobody's going to breathe through their nose if they feel air hunger. That's the reality of it. So we want to alleviate the air hunger.
This was one of the hardest things I had to do when my kids were younger. And I know we were collaborating quite a bit when both our kids are about similar ages. My children at the very, very young age of 2 and 4, she was like a guardian angel. The myofunctional therapist came, Lori Frey came, and she traveled an hour and a half to come help me. And she told me, she looked at the kids, she evaluated them. They were both mouth breathing, and they both had tonsils and adenoids that were swollen. And I was like, why are they swollen? And, after I had gone to the ENT, they wanted to cut out those lymphatic tissues. They want to actually cut them out. And I'm like, tell me why. So I went and got them allergy tested. My son that was born premature, about 5.5 weeks premature, he was basically allergic to anything environmental. And my daughter was not. So I knew it was not that. But when Lori came and evaluated them, she said, you need to close their mouth at night. And I'm like, okay. So that was the hardest thing. I tried to convince my husband. He thought I was crazy that I was going to put tape on their lips. And lo and behold, I took her advice. It was very scary. The first night I was watching, my son couldn't. My daughter, at 4 could. My son, I had to wait till 5 years, and that was like 3 years later. Anyway, I did for my daughter, and I watched her, and she was fine. She was, sleeping calmly. And little by little, we kept checking in with the ENT. The swelling went away. The adenoids went away. The tonsillar swelling went away. So, I'm a big believer that if you keep your mouth open, you just introduce all that, bacteria and all the stuff that's in the air hits your lymphatic tissues. They stay chronically swollen. So we cannot use our nose to filter that air and to release nitric oxide. We're not going to be able to deswell these young children's swelling that is occluding their airway. So your myotape is brilliant because it doesn't cover the mouth, and the parents are a little more not as scared to do it. I didn't have that during my kids' young ages. I just had the 3M micropore tape, and I still tape with that every night, and I love it. I can't not use it. Now, I want you to comment, because this is something new that came out in a recent study around puffing and why it's not that smart to just put on tape. So I wanted you to comment on that and share with everybody what you think around mouth taping.
Yes, this was an interesting paper that was published back in 2022. So basically, they had individuals wear a mandibular advancement device, and on one night they had no device, one night they had the device, one night they had their mouth taped, and one night they had both mandibular advancement device and mouth taped. And if we look at the results, now the mouth that was taped fully. So here we have baseline here. So this is with no intervention, no mouth tape, no mandibular advancement. And then on this night, it's adhesive mouth tape. And this person here got, a little bit better. This person here, significantly better, but this person here got worse. This person here got a tiny bit better, but this person here got worse. This person here, better, got worse, better.
Right.
You see it. So we have to ask then, what was causing that? And mouth puffing seems to be the real cause of it. And mouth puffing is, if air has to leave the body, it has to leave the body anyway. And I was trying to figure out what was mouth puffing. So I jumped on to the elliptical, an exercise bike kind of thing. It's not really, it's kind of like a skiing machine or something. But anyway, I ramped up the speed, maintaining nasal breathing. And at some point the intensity of my breathing was too much that the air has to get out of the body some way. So you puff out through the mouth. And the same is going to be happening during sleep. The air has to leave the body some way, and the air is puffing out through the mouth. But if we tape the mouth, then the air can't leave the body so easily, and that will worsen the AHI. Now, I'm also going to say this. If we look at the results though overall, it's pretty impressive, as in terms of the application, or even with people with mandibular advancement devices to get their mouth closed during sleep. 76% of individuals achieved an AHI of less than 10 events per hour when they wore the mandibular advancement device and the adhesive mouth tape, versus 43% when they only had the mandibular advancement device. So the application and getting the mouth closed is very important, whether the person is on MAD or whether they are on a CPAP or whether they are just, if they have no, device whatsoever. But mouth puffing is like this.
Yeah.
That's what mouth puffing is. We can't stop that. Like, I'll just show you in terms of because sometimes people say, well, how do you know that your tape allows mouth puffing? So this is just a tape that I have here. So if I put it around, I stretch it, and I kind of have to adhere it. So there's a pull here pulling my lips together. So that's encouraging my lip closure. Now, if I need to mouth puff, I can. So it doesn't prevent mouth puffing. So it's not going to worsen sleep apnea. It's not going to increase the risk of it. But for those individuals who we can help. But I will also say, it's never just about, if somebody has sleep apnea, it's never just about just taping them out. Taping them out isn't enough.
Absolutely. It's reducing the volume. The sleep apneics, they just don't realize that they're breathing 3 times the volume. They don't understand that concept. And I try to teach it to them. I try to get them to understand and learn the reduced volume breathing concepts and exercises. And it takes time. It takes time. I always tell people, I'm like, it's going to take about 1 year to transform your breathing. People don't like to wait that long. So the hardest patient that I see are those patients. I get patients from dentists, ENTs, neurologists, sleep physicians, sleep dentists. The hardest ones are the ones with anxiety. They are told to slow down their breathing or to reduce how big, and then they get nervous. And some of them, their nose don't work. Some of them, I try to get them to go see an ENT and to consider surgery. Some are going to do it, some aren't going to do it. So it's difficult. These patients, you try to start transforming their breathing and they're anxious. They have panic attacks. So can you share around any difficult cases that have anxiety that you've dealt with and how you've dealt with them? How have you worked with them to get them to slowly transform their breathing so that they're not having these panic attacks, that they're not having these anxiety moments? Can you share with us what your style of teaching is?
I think it's very normal. If somebody has anxiety or panic disorder, if they have an episode, their breathing is impacted. Anytime the person is anxious or if they have hyperventilation attack or a panic attack, their breathing is affected. They breathe faster, they breathe harder, especially if they have a panic attack. They feel that they're not getting enough air. It's quite terrifying for them. So they can have a conditioned response and they may not have a good relationship to their breathing. And even just when we direct attention onto their breath, it can generate some degree of fear because it's almost that they are living a past episode that they've had. So the exercise that I typically like to start off with, because I've made plenty of mistakes with panic disorder, plenty. And I have put people into panic attacks. I didn't do it intentionally, but I didn't realize that that kind of relationship that they had with their breathing. I always start off with small breath holds, first of all. Number one is you don't have to pay attention to your breathing. And number two, the small breath hold, the breath is held at the end of an exhalation, which helps. It's almost like slowing down the speed of the exhalation, which helps to stimulate the vagus nerve. And from that, then I have them do small breath holds while walking. And I want to expose them to a small degree of air hunger to help desensitize their body's reaction to suffocation. But I also want to get the nose open. So say, for example, I might take them small breath in through the nose, out through the nose, and pinch the nose and hold for 5, 4, 3, 2, 1, let go, breathe. So we have them do that, for a few minutes. And then I have them walk. Small breath in, small breath out, pinch the nose and hold, and walk for about 5 to 10 paces, just holding your breath. To give them a teaspoon of air hunger. That also will help to decongest their nose. And then I will focus on breathing exercise, especially if I feel that they've got quite a strong sensitivity to carbon dioxide accumulation, or if they've got quite a strong reaction to the sensation of air hunger. Now, they call it suffocation, and they don't like it. They are terrified of it. So the most natural way to improve breathing patterns is to do physical exercise with the mouth closed. By far and away the most natural way. Go for walks with your mouth closed, dance with your mouth closed, yoga with your mouth closed, whatever you do, just do your physical exercise with your mouth closed. And when you're breathing through your nose during physical exercise, there is an extra load to your breathing, because as you do physical exercise, of course, you're going to produce more carbon dioxide. But if your mouth is closed, there's going to be an accumulation of carbon dioxide, a slight accumulation, depending on the intensity of exercise, but a slight accumulation of carbon dioxide in your lungs and in your blood. So you are exposing the individual to a slightly higher carbon dioxide. And that's good, because that can help to improve their tolerance of that gas. Secondly, if they're breathing through their nose, you typically have a better recruitment of the diaphragm. So this can help to improve their breathing from a biomechanical point of view. And thirdly, breathing through the nose during physical exercise, they can do it without having to have attention to their breathing, but we can also increase blood flow to the brain. And increasing blood flow and oxygen delivery to the brain is regarded to reduce brain cell excitability. And there's different paradigms now in the anxiety population, but one psychiatrist is coming out quite a bit with it, a guy called Dr. Michael Binder. And he recognized that patients with anxiety, that they've heightened neuronal excitability. Their brain cells are really firing all over the place. And one way to help to quieten the mind in terms of that way is increasing carbon dioxide in the blood, because carbon dioxide is a vasodilator and helps to increase blood flow to the brain. And a very natural way to increase carbon dioxide is simply do your physical exercise with your mouth closed, both breathing in and out through your nose, and exercising at a pace where you can sustain nasal breathing. Yes, you feel air hunger, but your breathing is under control. So it's not that we're asking somebody to sprint with their mouth closed. We don't want excruciating stress or anything like that. We want to have, yes, you feel that bit breathless. You might have to slow down a little bit, but think of all the benefits, because when people think about breathing, there's very often an idea out there that the more air you breathe, the better. And I have no idea where this idea came out of. In the yoga world, I kind of have an idea, because I wrote a book a couple of years ago, and I was writing the book on it. A PhD researcher reached out to me, Magdalena Crawler, and she'd just done a PhD thesis on yoga breath. And yoga breathing, up until about 1880, was all about breathing light and breathing subtle. And after 1880, an idea took hold that if you took these full deep breaths, especially in 1880 thereabouts, there was a condition called tuberculosis that was quite rampant. It affected the lungs. And the individuals back then thought, well, if you took full deep breaths, it prevented germs from spreading throughout the body. So that's where the full big breath came out of. It absolutely makes no sense whatsoever, because the more air we breathe, the more carbon dioxide that we remove from the body. And as a result, our blood vessels are constricted and we have reduced oxygen delivery. And people understand this, like I'm sure there's plenty of even our listeners that you've got into a stressful situation and you started taking full deep breaths. Even if you're slowing down your breathing, you could slow down your breathing to 6 breaths per minute. But if you're taking a full big breath, you're still breathing 16 to 18 liters of air per minute. It's too much. And this is reducing blood flow to the brain. And this is causing arousal of the central nervous system. I think in short, Jenny, like when I'm working with my anxiety clients, and the problem with anxiety, of course, is that there's a lot of living in the head. There's a lot of rumination, and there can be a difficulty, of course, getting the person out of their mind. But I often ask them, just keeping it simple, how do you breathe when you get stressed? And they tell me, well, my breathing gets faster, gets harder, I feel I'm not getting enough air. I often have my mouth open, my mouth is going dry, I'm breathing upper chest. And then I say, okay, so that's how you breathe when you're stressed. But we also have to bear in mind that you could be breathing a little bit like that all the time. And if you're breathing a little bit like that all the time, what's your body telling the brain? And it is going to feed into a stress response. So we want to tell the brain that the body is safe, because that's all the brain wants. The primary purpose of the brain is to make sure that the body is safe, to look after the body. So then I ask you, well, instead of breathing faster, then what can we do? Well, we slow down our breathing a little bit. Instead of breathing hard, we want to breathe light, breathe soft. We shouldn't be hearing our breathing during rest, and even soften it a little bit to the point of, a slight sensation of breathlessness. Don't use air hunger, don't use suffocation, because that just brings on fear, but even a slight feeling of breathlessness. And of course, then we want to work with breathing from high down to low and breathing in and out through the nose. And, there's so many cycles here, though, because if we think about our breathing patterns, our everyday breathing patterns is going to feed into our state of mind. Our everyday breathing also feeds into our sleep issues. If we have poor sleep, we have greater rumination of the mind. If we have greater rumination of the mind, we have poor sleep. If we have greater rumination of the mind, it can affect our breathing. So we have this triangle with one thing connecting into the other. And, that's why I think there's a number of aspects we have to give, or I think it's very important to give people the tools to be able to self-regulate. You're going into a stressful situation, a challenging situation. How does your breathing react? What can you do to control your physiology? And that's the one thing about the breath. We do have some degree of control, but I am going to say this,
Right.
not all breathing exercises are the same. People, when they think about breathing, they often think, oh, this full big breath. It's the greatest load of nonsense that has ever crept into the world of breathing. And I think it's important that we do our best to educate people on that.
Right. I so agree with you, Patrick. I like your approach around anxious patients and not focusing on their breathing, but getting them moving during activities and working on nasal breathing. I really like using the capnometer. I use it on every new patient and every progress visit. And we actually use it to train patients to understand like where they are at that day, at that moment. But it tells me how fast the patient's breathing and what their CO2 levels are. So for me, so many people don't think they have a breathing problem. They say, no, I breathe through my nose just fine. So that I put it on and they're breathing 30 breaths per minute. And I tell them, you know what, you're supposed to be breathing 10 breaths per minute, sitting here, not moving around exercising, but just sitting here. And they're surprised. And so that gives them a little buy-in to this breathing problem that they don't realize they have. So if you're a PT listening to this podcast, or a dentist, a medical doctor, a speech therapist, a myofunctional therapist, I wanted to share with you the course I've developed that I've been developing over the years, but it's a compilation of all the years of connecting the dots, going to all these conferences where I'm the only PT because I'm curious about how other disciplines treat similar patients. We don't all talk amongst each other. I'm always trying to create a team approach because I can't do it all. I can't. I need all the team members, and I need them to understand that we are a team in the healthcare of each airway compromised patient. So I've incorporated what I've learned from you. You have such a way of connecting to so many people in the public. You're so good at that. And people just don't realize they have a problem until you've touched them and have them understand. I think you're a great person to learn from, and you have such a good demeanor teaching. So this program, it's really my way of getting people up to speed. So many people, medical doctors included, don't know how to look at the airway, don't know how to even understand how to identify people that aren't breathing well, that are breathing compromised, are mouth breathing or chest breathing, and their posture is different. So I'm trying to help, transform the way we look at our patients. As a healthcare, system in the US, I think it really needs some change. So I brought in my PT background from my head and neck physical therapy concepts that I've learned from my mentors, Rockabato. I've learned from myofunctional therapy, understanding the whole craniofacial development part, my oral posture training, how to stabilize the throat, how to do suction to create that stability, how to transform nasal breathing thanks to you and sleep, and then how to stabilize the cranial nervous system. That I learned a lot through learning from Dr. Lois Laney, who you're going to be hearing next in the next podcast. So I wanted to share this QR code for you if anyone's interested in learning how to integrate everything. It will It's taken me many years to get to this point, but I want to give back and like teach what I've learned. And that's what I'm doing this year. I've brought in all the different doctors that I've learned from. And Patrick, you're one on that program, and you have a voice. You taught me a lot about how to change people's volumes of breath. That is huge. How to transform their sleep. So let me just show you that. It's this QR code if you're interested. Take a quick look here. So you can use that if you're interested in learning from me. That's going to be happening in Chicago, Calabasas, California, and Bethesda, Maryland, right outside DC. Okay, and I'm going to ask a few questions from the Q&A, the chat. So let's take a quick look here. Okay. Why is the lower AHI in women mean more than the same number in men? Could you share your anything you know around
Very
that?
interesting, Bella. I don't have an answer, but that was the findings, and I mightn't be able to pull up the reference so quickly, but what I could do is send it on to Jenny. You know, I think it's just one of those quirks. Women breathe differently to men. Women sleep differently to men. And I think there's something that's going on with women's sleep that needs a conversation around. So the only reason that I kind of put it out there, because there must be a lot of women who do a sleep study or who have symptoms associated with poor sleep and upper airway resistance syndrome, and they don't even realize it. And possibly they're falling between the stools of, medicine and sleep, because maybe their doctor, their GP doesn't realize it either. So, yeah, I don't have an answer. Why is it that women have different symptoms, and why that if they have an AHI between 2 and 5 events per hour, that it's equivalent in terms of symptoms of a man between 10 and 15 events per hour? It has to be a number of things. It has to be the structure of the airways. Could be the chemosensitivity to carbon dioxide. There's a difference. Women's airways are different to men's.
Okay, I have a question for you. There's also a lot of curiosity around sleep tracking devices like the Aura Ring, the Whoop, or sleep apps that measure breathing rate, HRV, and deep sleep. How reliable are these devices in measuring breathing quality? And do you recommend any particular device for patients trying to optimize their breathing?
Yeah, I'm not good with data. I've no apps. I've no apps on my phone, no social media, no nothing. I have nothing, not even a watch. So I'm probably the worst person, but we do have staff here and they like Whoop. So, and they're tracking it via Whoop. How reliable is it in terms of heart rate variability and that? I don't know. But like one of our individuals, he said, yeah, I got Whoop for Christmas. And he is about 48 years of age. And he just noticed himself, if he had 2 or 3 drinks of alcohol, that even if he felt fine the following day, his Whoop would tell him that he had lighter sleep. And that kind of recognition was very important, because that kind of told him something, that, okay, alcohol is not great for your sleep quality. Now, his son also has a device, but on one occasion, his son woke up and his device told him he hadn't slept well, even though he had slept well and he felt absolutely fine. But because the device had told the son that he hadn't slept well, the son didn't want to play sports that day. So I think, I think there's a place for wearables, but just bear in mind that depending on some people's personality, you don't want to turn your sleep into a performance. And there might be a tendency that if you are wearing a wearable, that you're conscious that you want to wake up and you want to have good stats. But now there's a pressure on sleep, and that's going to hamper the very thing that you're looking to improve.
Very good advice. Thank you. Big good cue. I have another question for you here from the audience. When Mr. McKeown says about anxious patients, does he mean those that have anxiety disorder or those that are having some anxiety around breathing? Can you comment on that?
It can be anybody really that, if somebody comes in, like we have a form that they fill out, it's including the Nijmegen questionnaire, there's other questions, etc. And we want to assess, do they have a degree of even high stress or racing mind, anxiety, whether they've been diagnosed with it or not, panic disorder, hyperventilation attacks, etc. And I never know by looking at a person, and nobody's going to know, when you start doing breathing exercise, you don't always know how they are going to react. But if there's a tendency at all towards anxiety, diagnosed or not, I always go easy, because if I go in a bit too hard with any breathing exercise, it just could push them over the edge, and I don't want to do that. So I go very, very gentle, almost baby steps, because a lot of these, people as well, it can be hard. They're living in their heads very often, overthinking, overanalyzing, and I want them to feel a success. So going real baby steps and just building it up over time. We've plenty of time, I've been guilty of going too hard and too fast before, and it doesn't work with some people. Some people it does, but some people it doesn't.
Okay, I have one last question for you. I always ask this to all my interviewees. What are the top three things that you think are important to be the healthiest person possible? What actions or what things in life can you do to be the healthiest individual?
Well, I'm going to put breathing in there, but one of the best things that I find is doing physical exercise first thing in the morning with my mouth closed. I think it's huge. I was guilty of not doing physical exercise because my workload had grown. Like we have 15 or 16 full-time staff. It's always quite busy here, and like I was putting everything to one side. And then I kind of was feeling, resentful, or not resentful, but guilty, or I don't know what the right word was, but I said, okay, I need to be giving myself some attention. And that's when I made a deliberate early first thing in the morning, I give myself attention. So I will do my physical exercise. I have an infrared sauna here at the office. I can do that. My gym equipment is all here too. So it's easier for me. But at the same time, I think we do have to prioritize ourselves. And too often we get caught up with everything else that's going on, and we look after everybody else and we forget about ourselves. You can only do that for so long. And so, yeah. So your question, Jenny, is in terms of health, I would say the biggest thing of the lot for me was getting out of my own head. It was absolutely the most important thing. Not spending so much time stuck in thought, ruminating, and bringing in, of course, breathing goes with that, but bringing in stillness and silence into my normal everyday life. And there's nothing woo-woo about it, but it gives you the ability to hold your attention. It gives you your ability to focus, to concentrate, to better decision making, not wasting energy unnecessary. Your sleep is better. I had a sleep book. I had a deadline to get 100,000 words written by Saturday 2 weeks ago, and I put 10,000 words solely on getting out of one's head. Solely. How do you get out of your head? 10,000 words. Because, I was kind of figuring well, is this for sleep? Will it apply for sleep? But, the problem is if we can't switch off an active mind, we're going to have poor sleep. And that will manifest as insomnia. So we have difficulty falling asleep, or we're waking up at 3 o'clock in the morning. And hyperarousal is really, really out there. It's out there with adults, and unfortunately with children and teenagers, So where's this all going? And of course, overstimulation in today's age. And that's a conversation. Social media apps, get rid of them.
Oh, I really, really like those three things. Thank you so much for sharing that and for your time. I hope to have you on this podcast again in the future. You are such an amazing teacher, and I thank you for all that you've shared with us tonight, all that you've taught me in all these years of collaborating with you. And thank you. Thank you. Take care.
Thank you for listening to the Breathing Lab with Dr. Jenny.